My name is Anna Fadich, and I am the Vice President of Men's Health Network, a national nonprofit organization that's based here in D.C. Our main mission is to educate men and their families where they live, work, play, and pray about different men's health information, educational programs around mental health in this case, but also different cancers and nutrition. So we have spent years working with the bipartisan Congressional Men's Health Caucus, currently co-chaired by Representatives Donald Payne Jr. of New Jersey and Markwayne Mullin of Oklahoma. We would like to take a moment to thank them and the Congressional Men's Health Caucus for making this briefing possible. We will be hearing from Congressman Mullin in just a few moments. We are honored to have you in attendance at this briefing today for veterans and active military, mental health, and suicide issues. As most of you know, suicide among veterans and active duty servicemen and women is an ongoing and unfortunately an often overlooked tragedy. A 2018 report from the VA using 2016 data says that the suicide rate for veterans was 1.5 times greater for Americans who never than for Americans who never served in the military. About 20 veterans a day across the country take their own lives, and veterans accounted for 14% of all adult suicide deaths in the U.S. in 2016. Relevant to us is that the suicide risk for veteran males is 90% higher than those of non-veteran adult men. We have a very distinguished panel here today to discuss these topics of suicide and mental health, so we're going to get started. A bit of housekeeping, we're going to have a question and answer session at the end, so please write down your questions, and after each presentation we may be able to take 1 or 2 questions for the speakers. Congressman Mullin, would you like to come up and say a few words?
Well, first of all, thank you, and thanks to all of our speakers for being here. This is a very, very important issue, and what a turnout. I really didn't expect that. We got a lot of things going on in the Hill right now, and so for you guys to take the time to simply come up here and talk about men's health with specifically the topic of suicide. We had 121 veterans commit suicide in Oklahoma last year, and every one of them were males. I have a good friend of mine to which I have probably spoke to him twice over the last 3 months, literally talking him off the edge. I could go through numbers and people to which I have had those conversations with, and men's fitness, men's health is more than just us being healthy, but it's the mental part of it too. And a lot of that comes down to a routine. Guys, a lot of times in our life, we can't control everything around us, but we can get a sense of accomplishment by having a routine of physical fitness. My routine is I get up every morning early, regardless of what time I go to bed, and I start my workout because in the mornings is the only time I can control. After that, I'm reacting, but I had that sense of accomplishment already completed, which a lot of time is enough to push me over to get the day completed. When we have our veterans that are coming back and they're getting out of the service, in the service they had a rank, they had a job, they had identity. And when they get out, they lose all that. I had a guy one time that was talking to me, a good friend of mine, ex-Green Beret, or I guess always is a Green Beret. And he was talking to him and he says, man, when I was in the service, I was in charge of multi-million-dollar equipment. I knew what my mission was, and we were good at it. And I come here and people won't even trust me with a shovel. And he's struggling. This guy currently is still struggling. He speaks for a lot of our veterans, men and women, that's coming back. And that's why our suicide rate is actually an epidemic that we're facing right now. And so for our speakers to be here, to give their time, for you guys to gather in this room, which is extremely warm, and to give your time, and bring awareness to this, we're all in this fight together. Because there's not one of us that could be in this room if our veterans wasn't out there keeping us safe so we could be here. As we said before, there's 1% of the population protecting 100% of our freedoms. And when they come home, we need to give them all of our attention. And if it's just giving them awareness, if it's just giving them a routine, if it's just letting them find their identity again, or as some say, find their why, then guys, I'm all in. So anything I can do to help, anything you need from my office, consider it done. And once again, thanks for taking the time. Speakers, I can't thank you enough. This is our 3rd time to schedule this, I believe. This wasn't ever scheduled for the 2019. This is called persistence. So we got it right, finally. God bless you all. Thank you so much.
Thank you, Congressman. Okay, we're going to get started. Our first presenter is Dr. Adam Walsh. Dr. Walsh currently serves as the Director of Research and Program Evaluation and as a subject matter expert for the Department of Defense Suicide Prevention Office. Dr. Walsh has 15 years of experience in studying and developing suicide prevention interventions.
Well, thank you. Ladies and gentlemen, I greatly appreciate it. Congressman Mullin, it's an honor and privilege to be here. Suicide is not always the easiest topic to discuss, but every time we do, we go around and we speak to many different audiences. We just the fact that lots of people are here and we're able to talk about suicide, especially among men, we move one small step closer to decreasing some of the stigma that does surround suicide and mental health, especially around men. We know there's a lot of stigma, and it's very difficult to talk about this issue. But every time we do talk about it, we talk about how complex it is. We talk about the different ways to prevent suicide. It certainly helps because we need all of you. We need the entire nation to help us with preventing suicide because it's a very difficult outcome to prevent, and to bring down our rate of suicide will take all of us. So thank you very much for being here and having me here. Thank you. So before I talk to you about some of the active duty suicide prevention numbers, I want to talk a little bit about our approach in the DoD. We take a holistic public health approach to suicide prevention. Certainly mental health, having access to mental health services, dealing with mental disorders is important. However, we know with many years of research around the world that it's much more complicated than mental health. There's a lot of different factors, environmental factors, situational factors that we must address. And so that's why in the DoD we take a public health approach. And we have a strategy that includes about 60 goals, or about 60 objectives and 14 goals. It's the defense strategy to prevent suicide, very much taken from the national strategy to prevent suicide. So these areas span from accessing, making sure that people do have access to good quality mental health care, but it also places equal importance on safe messaging, making sure that we talk about suicide in a responsible way, that we have communities engaged in suicide prevention, that people understand what are some of the factors that increase risk for suicide, and that we know the protective factors as well, that we have peer support, and that we have lots of community people understanding how we can support individuals who may be at risk for suicide. We also know that alcohol and drugs are important in having policies around those issues. And then also access to lethal means of suicide. We know it's important to store medicines safely. We know that it's important to have barriers on bridges, and we also know that it's really important to safely store firearms, because suicide can many times be an impulsive act, and so it's very important to keep environments safe around individuals. So what you'll see here is active duty service member suicide rates. And what you'll see is from 2010 through about 2016 is that, and a little bit before that, is that the rate has stayed. I'm going to be talking from a statistically, kind of a statistic standpoint, in terms of the rate has stayed kind of stable. So every suicide is a tragedy. We don't want any suicides, but in terms of understanding what is the rate of suicide doing in the active component, we know that for the last 7 years it stayed about the same, and that's not acceptable to us. We want it to go down, and so we are doing whatever we can to bring that rate down. Okay, in terms of males, we know that males are approximately about 4 times more likely to die by suicide than females. And the reason for that, in many different research studies, is that men usually use more lethal means of suicide. Men usually use a firearm to die by suicide. And using a firearm in suicide, it's about 93% fatal. So compared to females, many females use medications, and that's not as fatal. So one of the main reasons why the suicide rate may be higher for men is because of the method that men use. Also, the military has a higher percentage of males, and so we, in the military, we have about 93% of our suicides are men. And one of the things I wanted to point out, what I said earlier, is that mental health is important, but we also know in our numbers, in our surveillance numbers, we know that over half of the individuals that die by suicide do not have a diagnosed mental illness. And that's very similar to the CDC for the nation too, is that a little over half of those individuals died by suicide do not have a mental illness. So this points out how complex it is. And also, this is important because what we want people to understand is it's not just the individuals that you think are chronically depressed or mentally ill that we need to be reaching out to or looking for. As I said before, suicide can many times be impulsive. So we need to reach out to individuals in the military. As you know, people who serve in the military have to be pretty high functioning and are functioning at a pretty high level. So many of these individuals, they may have a lot of situational stressors. Relationship problems are one of the top stressors in the military, along with financial issues. And so some of these stressors we need to pay attention to. So maybe this isn't the individual who is always isolating himself or looking sad or depressed. This person might be situationally going through some very difficult times. We want to reach out to that person. But we need to open our eyes and open our minds that this person may not be that stereotypical person who we think is depressed that may be at risk for suicide. Okay, so help seeking. This is one of the things that is very important in our department and something that we've known for a while, and we need to continue to address. We know that men have a hard time asking for help when they're having a problem. And what we know in our recent data and the data that we've collected is that more than 2 in 5 service members would not seek help if they thought of suicide. So that's troubling, and we know why. They've been telling us why for a while, and that's because they're concerned about the perception of being broken. Also, they're worried about their career and jeopardizing their career, and desire to fix one's own problems. And we've been seeing the same data and these same reasons for a while now. And many people, many service members, they don't want to seek a clinical provider. They want a peer or they want a friend. They would like those individuals to help them. And that may be due to just their comfort, but it also may be due to their concern about their career. And we know that especially officers, male officers, senior enlisted, they're very concerned about their career and seeking help. In fact, in a survey in 2016, about 79% of the Air Force officers said that they would not seek help because they were really worried about their career. And so this stigma, this concern is real. And so this is one of the areas that we're really focusing on, is how do we increase help seeking, and what are the other options? We know there's clinical treatment, but service members are saying they want other options. So we're trying to work with the DoD and other agencies to make sure we provide multiple options for help seeking. So here again, you can see the top reasons for why service members would not seek clinical care. So one of the questions that we asked on the status of the force survey, which is a DoD-wide survey, is we know that one of the risk factors or triggers for suicide is feeling trapped or stuck. And so one of the questions we asked is, if you felt trapped or stuck, what would you do? And the majority of service members said they would deal with it on their own, 71%. And then also about 50% said they would ask someone, and then self-help or avoid the situation or ignore the situation. And so a lot of people, a lot of service members, they want to fix it on their own. Right. So what are we doing to address some of the barriers to help seeking in the military? One of the things that we have found in some of our research is that service members are more likely to see a chaplain if they're going through a difficult time. One of the reasons is because a chaplain is completely confidential. And if you look at the data, many service members are apprehensive about seeking clinical treatment because of the potential ramifications for their career. So they will seek out a chaplain. So what we have done in the department is we've invested some training and resources in training up chaplains in suicide prevention, recognizing the risk factors for suicide, and then using some evidence-based approaches to helping that individual manage that person's thoughts and behaviors of suicide. And so far, our data looks pretty good. We are able to train chaplains on some cognitive behavioral strategies. And these are some of the same strategies that somebody would receive if they were going to go to clinical treatment and receive cognitive behavioral therapy. Another thing is training chaplains just in evidence-based counseling and how to do reflective listening and how to identify the risk factors for suicide. Another thing that we're working on is a barrier reduction intervention, where we're going to be training service members how to ask for help. We know that they will need help at some point in their life, so let's go ahead and practice what you would do to get ready for a situation where you may need help. Another area we've known for a while is the data shows very clearly they want their own skills. They want to be able to solve their own problems. So in the Navy right now, we're doing a trial of an intervention where we're training young service members, 17, 18, 19-year-olds, how to learn how to do problem solving, emotion regulation, some of these core skills that we know protect against suicide. Also social problem solving, good interpersonal skills. We also know that that's a good protective factor, so that's also one of the new projects that we have going on. So I greatly appreciate it. I see the 1 minute, so thank you very much for your time.
Great. Thank you, Dr. Walsh. We have Congressman Crow. We have Congressman Crow here, who is going to say a few words. He represents Colorado. Thank you so much.
Thank you for inviting me to come here and attend. First and foremost, it's encouraging to see a packed room, right? Because it's a recognition that this is an issue that cuts across political boundaries, that we have a commitment to our veterans, to our active duty service members, and to their families to take this seriously and to really have an all hands on deck approach between our agencies, the nonprofit sector, and everybody who recognizes that this is an issue that we have to address, and we have to address with the sense of urgency that I see all of you have by being here today and the work that you all do. So I appreciate that. But I think it's also important to say that none of us really want to be here either, right? The fact that we have this crisis, that we have this issue, that's pervasive across the veterans community and our active duty military is a difficult challenge. And I wish that we didn't have this problem and that we wouldn't have to be dealing with it in the way that we are. But it is a problem and we are going to deal with it. So I look forward to working with all of you to address it. I'm a former Army Ranger. I served 3 combat tours in Iraq and Afghanistan before jumping into politics. And the prior speaker was talking about the warrior culture, right? And I served in the 82nd Airborne Division in the 75th Ranger Regiment, so I saw and it was a part of that warrior culture for many years. But it serves as a huge barrier, as many of you in this room know, a huge barrier to getting the help that folks need, right? Because if you are in combat, a man or woman in combat, it's not a question of whether or not you have some issues that have to be dealt with as a result of that experience. It's a matter of what type of help do you need, right? Nobody goes in to combat in that type of experience and comes out an unchanged person. So we need to change the culture at the top. We need to reinforce a leadership cultural change that recognizes that you are not weak for wanting to seek out help, that recognizing that we are all human, that this is not necessarily a natural experience for people to go through, and that it is a sign of strength to seek that help, but also that we have a commitment to each other, right? That we had battle buddies in Iraq and Afghanistan. There's a lot of veterans in the room here, right? You are responsible for the health and the welfare of your battle buddy and your fellow soldier. So addressing it at that level and making sure that from the very top of the Pentagon all the way down, the very top of the VA, all the way down, that everybody recognizes this as an issue, that we are addressing it is going to be really important. I look forward to working with you to do that. I'm going to continue to push for that at my level as well. So thank you again for the opportunity, and thank you for dealing with this today and every day.
So our next speaker is Dr. Keita Franklin. Dr. Franklin is a member of the Senior Executive Service is the National Director of Suicide Prevention for the U.S. Department of Veterans Affairs, Office of Mental Health and Suicide Prevention. Dr. Franklin serves as the Principal Advisor to the VA leadership for all matters pertaining to suicide prevention.
Okay, very well. Thank you so much. I'm also, is this turned on? Equally happy to be here this afternoon with these esteemed colleagues from the Department of Defense and SAMHSA and our nonprofit partners as well, and equally impressed by how packed the room is here. So I feel like the pressure's on to make sure we give the best content, and I also want to make sure I build on the existing work of Dr. Adam Walsh. We hear a lot in the press, and it's absolutely the case that 20 veterans end their life by suicide, but I'm not sure you hear that 123 people end their life by suicide every day. And so it is absolutely, and you'll probably hear more about this from my colleague Richard McKeon, but it's the 10th leading cause of death in the nation. And so it is absolutely a serious issue and deserves all the work and the efforts that are going in to prevent it. And the important thing to leave this room is that it's absolutely preventable. There are things we can and are doing to get after the issue. And so I want to make sure I run down some of our veteran-specific data, building on the existing data that you heard about from the Department of Defense. Within our veteran population, I get asked the question a lot, are our veteran rates higher than our civilian rates? And I will just tell you, yes, 1.5 times higher. When we compare like-matched populations from veteran to civilian and non-veteran cohort, and I can tell you what we think about that and why that might be. Equally so, when we dig even deeper, you start to see some of the at-risk groups, and so I will tell you that for years as a social worker in the field, we focused a lot on what we called men over the age of 55. And I should have opened my talk by thanking the Men's Caucus for leading in this space and putting this this group together, because I'm so pleased that you all are taking a leadership role on a topic as suicide. I know you could take on many issues. And men over the age of 55 has always been an at-risk group when we've studied it out. But I want you to know in our veteran population that over the last year or two, and we've peeled back the onion on the data, we see that our highest rate is amongst 18 to 34-year-olds. And so this is a different way of looking at the data, and it tells us that we need to bring different solutions to the table when you're thinking about age demographics and what we know about the cohort of people that have come up through the military and are in that age group, 18 to 34. I will also share with you that we do continue to look at men over the age of 50. In part, we have more of them in the veteran cohort. And so that's also, when you look at our data, you see the raw numbers are higher over the age of 50, but the rate is highest amongst 18 to 34. It's just a small nuance, but just the difference between rate per 100,000 and raw numbers. So I want you to know about that. Also, an issue around females. Female veterans are, 1.6 times more likely than their non-veteran cohort matched counterpart. And maybe some of you that have been in the field longer might have heard this notion that men complete more and that females attempt more. In part, men use more lethal means. And so when they're using a firearm, there's just often no going back, right? Versus medication, where we can make a save, or some other method. And so we have more male veterans, as they do on the DoD. We have a higher rate of females. Also, I want you to know some of the other at-risk groups that we're trying to dig deep on, and that is veterans that live in rural areas. I just offer that, and to the extent that some of you come from rural areas, that ties closely to access to means that might be more prevalent in some of those rural areas, as well as just access to services. So this notion of any and all manner of complication getting people into care can become a barrier. So when there's a long drive, when there's a long wait, and so anything that we can do in the VA to eliminate those barriers, we can and are doing. And so that's a little bit about our data. But when you look more holistically at the risks, I want you to know that the risks for suicide are sometimes similar to the risks for other ills in society or problems that you might think of. So when you look at the risks for domestic violence, or for substance abuse, or for child abuse, or for even sexual assault in some cases, the risks can sometimes be quite similar. And when you look at things that protect against those issues, again, there's a family of buffers or protective things that are also quite similar. And just one of the, I think, most exciting things about working with the veteran population is the notion of peer support. And you heard about it from my colleague, that they like to rely on one another. This sense of belongingness is a big protective factor. So if you walk the dog backwards from that, isolation is a big risk factor. So when we can bring veterans together and make sure they know that they continue to have a mission, a purpose, a sense of belongingness, and that they matter to one in each other, then we know we're doing the right thing. Equally so, I fully am on board with Dr. Walsh's comments about mental health. When we look at our data, it is interesting when you can look across 3 federal agencies and see that the data is quite similar around this issue. About half have a known mental health issue, and about half don't, which is why we call for what we call like bundled strategies, like certainly continue to invest in mental health, which the VA has done. Hopefully we can talk more about some of those, whether it's telemental health or opening up access and things like that. But also, we as a nation must invest in all sorts of capabilities that come together with mental health to really get to a point where we're making a difference in terms of a reduction. We've most recently, I want to talk to you a little bit about the what we're doing about it part of the story, and that is because we've just kicked off these things called Mayor's Challenge. I don't know if anybody's heard of them. The VA has had great success with this before my time in the homeless area. So we're sort of adopting a best practice from that field, but we are working with 27 mayors and cities. And what it is we bring them under the direction of Richard McKeon, who you'll hear from, in partnership with DOD. We bring them in and we just teach them the best evidence on how to get a reduction in their community, because it is really a local issue. Like preventing suicide it's a person-to-person sort of issue, and they will do it the best locally. So we bring them in. And we bring in all of their movers and shakers in their communities who get after suicide, and we train them up on making sure that their messaging is right, that their peer support is on target, that their mental health is evidence-based, and that they're working with their media properly. And we just train them up, and then we work with them throughout the week on a local plan. What does your local data tell you? Who are your local influencers for getting after this issue? And then what are your measures of effectiveness over time? So 27 cities are doing this, and now you'll hear soon. I think that we're close to releasing it on a press release. It's probably okay to share. We have 7 states that are now coming to the table, and so we're moving out with a governor's challenge. I have a test to myself at some point to memorize these 27 states and 27 cities and 7 states, but I have my cheat sheet here should anybody want to know what the states are. But we're pretty excited about that because we think when we're at year 1 and when we fully implement it and get the folks trained and they get intensive technical assistance from SAMHSA over time, that we'll start to see the reduction not only in suicide but in other high-risk behavior in these communities and cities. So I'm pretty excited about that work. Equally so, we do have a strategy. Our strategy, which we're passing out, and there's a placemat that I see some of you have that is sort of the one-page version of the strategy. Know that the strategy is not the VA's strategy. This is our nation's strategy for preventing suicide. So the idea is that you could pick it up and like you could look through it and do something, or you could do something. You'll see some call-out boxes like, what can I do where I sit? Because it is truly a national issue. And so the strategy is also built off the national approach where we have a number of goals. And one of the things I want to draw your attention to in the strategy is that we have a focus on building partnerships. We have 60 partners in our portfolio right now that we are matched up with. And the thinking behind this partnerships, I call it with my team, like we're trying to just crawl all over this space so that the partners are then equipped to do work with us and for us. We know that VA must lead and that it is our responsibility to prevent veteran suicide. Absolutely, that's our going in position. But when I can have an employer that employs the most veterans, take our training called SAVE, which is available online. I can get it to you if folks are interested. But if I can have them take our training and help us prevent suicide, if I can have them pass out our veteran crisis number, if I can have them develop peer mentoring models in their workplaces, if I can have them make sure that they're helping their veterans get access to health care when and where they need it, where they live and thrive, that's when I know I'll be doing good work. Just trying to shift our thinking away from a model that says, let's sit in our hospitals and wait until people come to us, to a model that says we're going to take it to them, like kind of like take it to the troops, move the programming to places where veterans live and thrive, and have many entities involved, vice just our own selves, is the forward thinking of what we're trying to do. I hope people are familiar with our campaign. It's, I think, the DoD and VA's joint campaign around Be There. If you haven't, it's hashtag Be There. Put it in. You should be able to pull up our website and all of our resources. As well, if I'm looking for my time clock. If I'm okay, I want to tell you too about ReachVet. We have this capability where we're doing predictive work in our hospital settings. And what it is it's a mathematical algorithm that maps about 160 variables. Each variable has a weighted value, puts them into an algorithm that then points to whether or not a veteran is at risk. Things like, have they missed an appointment? Are they diagnosed with opioid abuse? Have they missed more than one appointment? What is their pre-existing health factors? Once that goes in, if it tells us that one of our veterans are at risk, this is the beautiful part of ReachVet. We then call them and do these outbound calls to just coach them right back into care. And they have a set script that they use. It's not as basic as this, but it pretty much gets after, like, we've reviewed your medical record and we're worried about you. We want you back into care. You're one of our own. You're our vet. And we just coach you right back into care. We just did first 1-year evaluation of ReachVet. It was rolled out well before my time under the leadership of Dr. Caitlin Thompson. And this is just an unbelievable capability because it just provides another data point when you're trying to save veterans' lives. And the first year evaluation, we looked at it across all causes of death, not just suicide. And we see that people that are identified as at high risk, as your sort of scientist in the room, independent variable and your dependent variable, death, we see that you are more likely to have life and to live, the all causes of mortality. Have you been in ReachVet? And we were able to reach you. Part of why I think that capability is so important is just that what's at the heart of a lot of the suicide prevention literature is caring outreach. Such a simple capability. Calling a friend, caring outreach. And so we this year have also implemented a similar model in our emergency departments. When people come into the ER, they are at high risk. And I've even read literature that speaks to the fact that the very visit in the ER escalates them more, right? So What we're doing now is when they leave the ER, we're doing caring outreach, and it's a phone call, and it's I know you were in our ER recently, and oftentimes people will leave the ER with appointments and things and follow on, and then it gets clumsy and bumpy. And did they really make those connections? Any of you that have worked in an ER, you just you worry when people leave you if they're going to get connected to all of this. And so important to know that when they're leaving, they're going to get a series of phone calls with a script. And so I'm looking at my fellow, and so I'll close there. But know that that I so appreciate everyone's attention to this issue, and I can't wait for you to hear from Dr. Richard McKeon as well, and see how all of this sort of maps together across the federal enterprise. So.
Okay, our next presentation is from Dr. Richard McKeon. Dr. McKeon is currently chief for the Suicide Prevention Branch in the Center for Mental Health Services of the Substance Abuse and Mental Health Services Administration, SAMHSA, where he oversees all branch suicide prevention activities, including the Garrett Lee Smith State Tribal Youth Suicide Prevention, the National Suicide Prevention Lifeline, and the Native Aspirations Program. Thank you.
Thanks. And to advance the slides,
Left and right.
Okay, great. Thank you. Okay, it's a pleasure to be here with you to talk about this incredibly important topic. And as Keita emphasized, that this is obviously a tragic issue for our service members, for our veterans, but it is also a national issue, right? That in 2017, the last year for which we have full data, over 47,000 Americans died by suicide. It's the 10th leading cause of death in the United States. Think about this. It's the second leading cause of death from ages 10 to 39, according to the CDC. Of even greater concern is that suicide in the United States has been increasing. A report by the CDC that came out earlier this year showed that suicide is increasing in 49 of the 50 states, and in half of those states, the increase is greater than 30%. And this is approximately over the last decade. So it's important that we see veteran suicide, and we, of course, have a special responsibility for our veterans, but that we see it in the context of this overall tragic national problem. So let me, and I'm from the Substance Abuse and Mental Health Services Administration, so let me mention a couple of things. According to our data, over 46 million adults in the U.S. report having any mental illness, right, with 11 million having a serious mental illness, okay? Among young adults, both major depressive episodes and serious mental illness have been rising, okay? There are higher rates of suicide, and people with serious depression or psychotic disorders, so mood disorders, psychotic disorders, have a rate that's 25 times that of the general public. And so it's very important for us to pay attention both to the entire context for suicide prevention, but also to the mental health needs. And one thing that's not necessarily well understood, in 2017, the number of suicide deaths in the United States was very close to the number of opioid overdose deaths. There were almost 47,200 suicides and about 47,700 opioid accidental overdose deaths. You may have heard the 70,000 figure, which is accurate. That 70,000 is all overdoses from any substance. But when we look at the magnitude of suicide, it is roughly equivalent to the accidental opioid overdose deaths in terms of numbers in 2017. Now, this shows you some of the data on suicide mortality. Obviously, one of the things that is most obvious is the greater mortality from suicide among men compared to women. Unfortunately, for both men and women, it has been going up. So we do need to pay attention to both. But in terms of where the bulk of the suicides are, I think the ratio now is about 3.5 men for every woman who dies by suicide. This is certainly a priority. for SAMHSA's leadership. Under the Cures Act, for the first time, there was established the position of Assistant Secretary for Mental Health and Substance Use. Dr. Eleanor McCants-Katz is the first person in that position. And so part of SAMHSA's strategic planning incorporates these issues. The Cures Act also called for the development of an interdepartmental serious mental illness coordinating committee, and part of the key recommendations for that are around improving suicide prevention, also about improving crisis care in the United States. And there are a number of things that are particularly important as part of a crisis system. Having someone to talk to who can follow up with you, and a place that you can go when you need help, and someone who can respond to you, potentially at your home, referred to as mobile response or crisis response. Let me give you an overview of SAMHSA's initiatives before I talk specifically about some of our partnerships with the Veterans Administration. So since 2005, after Congress passed the Garrett Lee Smith Memorial Act, SAMHSA has been making grants to states and tribes around youth suicide prevention. All 50 states at one time or another have gotten these grants. All 50 states don't have them at any given point in time. But one thing that's really important to know is that our evaluation of these efforts have shown that counties that are implementing Garrett Lee Smith activities have lower youth suicide rates and rates of youth suicide attempts than matched counties who are not. So that is very encouraging. Unfortunately, when we look closer at the data, what we see is that in the counties that are implementing the youth suicide prevention activities, basically suicide is staying flat. And in the other counties, it's going up significantly. So that's where so it's like we're kind of battling youth suicide to a draw, almost. So while these are very encouraging results in some ways, they also show that there's a lot of work that we need to do. SAMHSA has also, since 2005, had a campus suicide prevention program that makes awards to community colleges, public universities, private universities around the country, focusing on mental health promotion and suicide prevention. More recently, we have been working with funding provided by Congress on adult suicide prevention. Garrett Lee Smith grants are by statute up to age 24. And so there we have what we call the Zero Suicide Initiative, which is working to strengthening suicide prevention within healthcare systems. Okay, and that's particularly important, right? Because we've learned a lot about how to help people who are suicidal. But we need in our healthcare systems for everyone to be aware of the work that's been done and to do it more systematically. That's what the Zero Suicide Initiative is designed to do, is to make suicide prevention central within healthcare. But it's also important to be aware that that's not the only part to suicide prevention. What's needed is a comprehensive public health approach. That's what we do in our youth suicide prevention grants. Because if we try to wait for people at risk to come to the offices of clinical psychologists such as myself, we're not going to accomplish what we need to do, which is to finally stop the tragic increase in suicide and begin to drive it down across the country. SAMHSA also funds the Suicide Prevention Resource Center, probably the best single collection of resources on that website that's found anywhere in the country. We're doing a lot of work on tribal behavioral health. Our Native Connections grants now go to over 140 tribes and tribal organizations across the country, focusing on preventing suicide and preventing substance abuse. And then we also have the National Suicide Prevention Lifeline. Last year, in calendar year 2018, over 2.2 million calls were answered by the National Suicide Prevention Lifeline. It's a network of 163 crisis centers across the United States. So these are your local community crisis centers that are in your districts that are working on this, networked using the number 1-800-273-TALK. I should mention that SAMHSA is currently working on, Congress passed and the President signed into law in August, the National Suicide Hotline Improvement Act. We are working on a report for the FCC, as is VA. We have a February deadline to them regarding the potential impact and advisability of a national 3-digit N11 number for suicide prevention and crisis intervention. And then FCC has 6 months to then make a report back to the Congress on that. Now, since 2007, SAMHSA's had a relationship with the Veterans Administration so that when somebody calls the Lifeline number, if you press 1, you are connected to the Veterans Crisis Line. About a third of those 2.2 million calls go to the Veterans Crisis Line. And VA has made a tremendous effort to build up the strength of those crisis centers. They now have 3, Canandaigua, New York, Atlanta, Georgia, Topeka, Kansas, to answer those calls. The other 2/3 where people don't press 1 get answered by your local crisis centers. Now, one other area that we are working closely with the VA on is we also have called the Service Member Veterans and Their Families Technical Assistance Center. And this is working together for VA and SAMHSA and HHS more generally and Department of Defense to try to reach veteran service members and their families, particularly those veterans who are not in VA care, who are on average 14 of the suicides each day. We all have a responsibility to be trying to work together to prevent suicide among those veterans. And so this is what this TA Center tries to assist with. And Keita mentioned the Mayor's Challenge. This is actually a slightly over older side because it doesn't have the 3 most recent ones added to it, but it gives you a sense of some of the locations participating in the Mayor's Challenge. And again, this is the idea that there needs to be a comprehensive public health approach that that involves a variety of people, workplaces, healthcare organizations, and members of the community of all kinds to work together to prevent suicide. So we're very excited about this work. That started last year. This year, we started work on what are called the Governor's Challenges. These are the 7 states that are engaged in that: Arizona, Colorado, Kansas, Montana, New Hampshire, Texas, and Virginia. SAMHSA also provides additional support to states around suicide prevention. We try to provide support to state suicide prevention coordinators who are typically part of the state government, many of whom have done some great things to try to promote suicide prevention in their state. But we all have to work together on this. Let me mention one other piece. I used to run a psychiatric emergency service and a hospital-based community mental health center in New Jersey. So I'm particularly, interested in the importance of crisis work and crisis intervention. It's got a little bit of a wonky title, the Crisis Intercept Mapping Initiative. But here's the idea. The idea is that we know that veterans who are in crisis, right, hopefully they're contacting the Veterans Crisis Line. But many are interfacing with community emergency and crisis services. And so what we're trying to do is to help make sure that those veterans get the care they need. If they, for example, go to a community emergency room, in New Jersey, when I was there, there were 2 VA hospitals. But if a veteran was brought to an emergency room, if they weren't in the 2 counties where the 2 VA hospitals were, they would be brought to a local community emergency room. It's important that all of those community emergency rooms have protocols for providing follow-up for them. And there's a particular reason, for that, and for work being done on services. I'm just about out of time, but let me emphasize the idea that care transitions are critical for suicide prevention. We could all wish that when somebody left an inpatient unit or an emergency room, that they had no suicide risk. That's not the case. Rather, these are times of high risk. And we need to be able to connect with veterans and other Americans in those circumstances in an ongoing basis. This is some of the strongest research in suicide prevention has shown if we do this, we reduce suicidal behavior. It has the potential for preventing deaths, injuries, and readmissions. So because the Action Alliance is doing work on this, the point of this slide is just to say, at a time when we can send a package halfway around the world and track it, we should not be losing veterans and other Americans within the gaps of our systems. So because this is not the floor of the House of Representatives and the Senate, and I can't ask one of my colleagues to yield me additional time, I will stop there.
Great, thank you very much. And we have one last presentation from Ms. Maureen Elias. Maureen serves as the Assistant Director of the Veterans Health Council of Vietnam Veterans of America, and she has a master's in mental health counseling from Bowie State University.
I need to tell you, I have actively been seeking ways to kill myself. First thing out of her mouth, it was my first day as a brand new mental health counseling intern at the Crisis Stabilization Center, and I had just launched into full-blown panic mode. My first day, and they have thrown me to the wolves. I am in way over my head. All I knew were statistics about suicide. I've never faced someone contemplating suicide. I didn't even know what to say. I have never even had a friend come to me and confide they were thinking about suicide. What do I say to this total stranger? None of my schooling in mental health counseling had prepared me for this conversation. I was completely at a loss for words. Once I regained the ability to breathe, I said as calmly as I could, "I'm so glad you came to me with these feelings. You sound like you are in a lot of pain." She opened up and poured everything out, and so we both survived my first day at the Crisis Stabilization Center. Through my direct experience, I learned that there are many false myths around suicide. As a society, we don't like to talk about it, and therefore we don't understand it, which makes it harder to solve. The numbers are rising. We have to take action because it is becoming a bigger problem. The fact that we are all here in this room together now means that we have gotten past our rock bottom moments. We haven't acted upon those feelings. But we have all experienced at least a moment in time where we either feel like I am messing up so much I should just stop, or wishing the ground would swallow us whole. For most of us, we feel we belong and don't perceive ourselves to be a burden, so we are able to carry on. This is not so for those contemplating suicide. Sadly, they struggle with the perception that they are a burden and no longer feel a sense of belonging. In Tom Joyner's book, Myths About Suicide, he peels off the blindfold and cracks open some of the more pervasive myths around suicide. I'm about to debunk 4 commonly held myths about suicide. And before I do, I'd like to propose a challenge for you. I'd like you to listen and count, honestly, how many of these you knew to be false before I debunked them. Don't worry, I'm not going to ask for your number. I just want you to keep track. They are myths for a reason. They are well known. The majority of people think these are true rather than false. The majority of even the smartest people in this room might be getting this wrong. I want to keep you in the know as you are on the cutting edge of information, and really, being able to help a situation is to understand it properly, which is what my organization is all about. Now, let's get to the 4 myths. Myth 1, suicide is an easy escape, one that cowards use. When I served in the Army, At almost every quarterly safety briefing, there was some poor schmuck who'd been selected for the suicide prevention training who would get up and yell, "Suicide is a coward's way of getting out of his responsibilities, so don't friggin' kill yourself, okay?" Only he didn't say friggin'. That's not very helpful, I thought to myself, and maybe it's wrong. If suicide is so easy, then why is it so difficult to do? The current ratio stands that for every 20 suicide attempts, 1 is completed. I don't think any of us would consider those who won the Tour de France cowards, and yet, of those 60 who have won the Tour de France, suicide occurs at a rate several hundred times higher than the general population. And I doubt any of us would consider the survivors of the Holocaust cowards, and the suicide rate among those survivors is the highest in human history. What these two populations do have in common, though, along with many veterans, is a shared history of experience with injury and pain that creates familiarity with fearlessness, which can prove fatal when combined with a desire for death. Myth 2. Most people who die by suicide don't make future plans. This one surprised me. I would think that one of the plus sides of knowing my life was about to end is that I wouldn't have to worry about things like paying the electric bills. I think I would probably tell my boss off. Not you, sir. You're great. You're wonderful. Someone in the past, a past boss. I wouldn't waste my time or money. I would have some fun. But individuals thinking about suicide treat responsibility like they normally do, because they are handling their everyday stuff while having much deeper, painful thoughts. The suicidal mind is ambiguous, with competing forces tugging at the suicidal individual from the sides of both life and death. People often make plans for jobs, trips, and relationships in the weeks before their deaths by suicide. There are two processes in their mind going on. The mundane that is going on in virtually everyone's mind, such as, what will I do this weekend? What do I need from the grocery store? Why won't this printer work? The other side, far from mundane, is difficult for those who do not struggle with suicidal thoughts to conceive of. Why don't I just die? There is an aspect of death that is almost comforting. People would be better off, so why don't I just get it over with? Myth 3. Suicide is selfish. Those who die by suicide have experienced a rupture in their social connections. They are alone in a way that few can fathom. In fact, there is an abundance of evidence that those who die by suicide believe incorrectly that their deaths will be a blessing to others. In their minds, the mental calculations tell them their death will be worth more than their life to others. Their minds are so focused on the here and now, on their pain, that even the most obvious consequences of their actions do not register. Let me give you an example. As I was in labor with my first child, begging for an epidural, the anesthesiologist was busy with another client down the hall, and my first true 100% contraction hit. Without even realizing what I was doing, I grabbed my beloved husband by his t-shirt, pulled him close to me, and bit him until my teeth touched. It wasn't an act of selfishness. I wasn't even trying to hurt him. Well, not really. I was just in such immense pain, I reacted, maybe overreacted. In later heated discussions with my husband over this particular reaction of mine, I attributed it to something like the desperation caused by the pain, which he should understand, right? Perhaps we too can envision those with suicidal thoughts as someone who is in immense pain, rather than someone who is selfish. And myth 4, if people want to die by suicide, we can't stop them. Can you believe that one? The really scary thing about people believing this myth to be true is that they might not try to intervene, to take action at all, thinking it won't make a difference anyway, as they will just attempt suicide at another time and place. Imagine if this were a loved one who had had a heart attack or a stroke, and the policy were not to intervene because they would probably just have another one. In fact, the opposite is true. Intervention can be very effective at stopping or preventing suicide attempts. at various places that have been super lethal to jump from, places such as the Eiffel Tower, the Golden Gate Bridge, or the Empire State Building, authorities put measures into place to help prevent further deaths by suicide. Measures as simple as a gate or suicide prevention watch volunteers are effective because most of the people who are stopped from jumping at these locations don't go on to die by suicide somewhere else. If the myth were true, those who were thwarted would merely find another place or means of jumping to their death. Okay, you've heard 4 common myths about suicide. Now I challenge you to keep track of your number. If you knew all 4 of these myths were false before I debunked them, you almost have superpowers. If you knew none of these were true, it's okay. Neither did I the day someone told me they were considering suicide. And that is why I'm here to help. These aren't the only myths out there, and I encourage you to look inside yourself and find some of the myths you might hold regarding suicide and question them. I would also like to take this opportunity to encourage the DoD, VA, and other healthcare providers to take a closer look at the entirety of the situation surrounding when a veteran dies by suicide, by stepping up efforts to conduct thorough post-mortem biopsychosocial evaluations from the veteran's loved ones, friends, and family members. What major life changes have occurred leading up to their death? Had they lost their job? Had there been a change in the family, such as the birth of a child, or a child has moved out? By looking at the whole picture, we can suss out the information, find the commonalities, and better communicate and reduce the factors that cause the perception that they are a burden or felt they did not belong. One example of this might be veteran employment. A lot of energy is focused on lowering the veteran unemployment rate, which right now is at an all-time low. So the unemployment rate has gone down, but the suicide numbers haven't really changed. What is missing here? What are we doing wrong? If just having a job were enough, why aren't the numbers changing? There are other things at work. This biopsychosocial would help us find what is still at play. How much effort is being placed into ensuring the employment is meaningful, gainful work? Or how many were underemployed? In a recent article by Natalie Gross in the Military Times, I shared my experience leaving the Army. I was a counterintelligence agent with a top secret clearance, fluent in Korean. When I utilized the VA Career Services, do you know what job I was told my skills qualified me for? An administrative assistant. You mean like a secretary? Could you check that again? I'm not sure how my lie detection skills or rapid rapport building or language is going to really help me as an administrative assistant. Maybe if I worked for the president. Thanks for such excellent advice, VA Career Counselor. This made me wonder. So our employment numbers are up, but is that number high because veterans are in soul-crushing or dead-end meaningless jobs? Which raises the question, how many veterans who died by suicide were meaningfully and gainfully employed? When we look to the life of a veteran who has died by suicide, perhaps we find they have lost their job. Their income stream has stopped. The veteran has begun acting out at home and turns to alcohol and drugs. Their spouse has decided they have had enough and has taken the kids and left. The house gets foreclosed upon and the veteran moves either to a shelter, their car, or the streets. The veteran has now lost their sense of belonging and perceives himself a burden, and the risk skyrockets. The VA has a mortgage guarantee program. They can tell when a veteran has fallen into arrears on their mortgage. I don't know if you have experienced this yourselves, but take it from me. Falling behind on your mortgage payment, even if for a month, is terrifying. It's scary. So this is an ideal time to reach out to someone, find out what is going on, and intervene. It might be possible for the mortgage program and the VHA to combine efforts to catch things before they spiral any further. By conducting thorough biopsychosocial interviews with those who interacted with the veteran who died by suicide, we could better find what things accumulate to the point where a veteran perceives himself a burden and no longer has a sense of belonging. Then we might really begin to make an impactful difference. Don't fall for the myths. Our efforts can really make a big difference. Thank you.
All right, thank you to all of our panel members. I want to open the floor up for questions. So do we have any questions? Yes, right here.
Can you talk a little bit about the mental health training process at MEPS or through recruiting? I think this is probably best for you.
Sure. If you want more detailed information, I can certainly get that, and I can give you a card, but I know that there is you know, basic general mental health screening that is done through MEPS and recruiting, but that is not my expert area. So if that's something that you would like, I'm more than happy to sit down and talk with you and also our mental health individuals.
I think the question that you might be asking, or the question under the question, so you tell me, is what pre-existing vulnerabilities are service members coming to the table with before they even join the military that might then be impacting them across the lifespan of their career and then into their veteran status, which I know Dr. Walsh quite well, and I know he does know that about the ACE pre-existing vulnerabilities.
Yeah, so you know, if they have certainly a chronic mental illness, certainly things like chronic depression, there's an accession process where they're not allowed into the military. So that's a standardized process, if that's what you're asking. Yes.
Is there another question over here? Yes.
Hi, I was wondering if any of the organizations that have spoken today are involved in any consumer research or survivor research where suicide attempt survivors are able to be involved in the design of the research and development of suicide prevention programs.
So at SAMHSA and our suicide prevention programs, we have tried to incorporate this in a number of different ways. We've tried to highlight the stories of hope and recovery of people who have experienced suicidal thoughts or have survived suicide attempts. We make this a requirement in many of our grants that the voices of people with lived experience are included in the efforts. So those are some of the ways that at SAMHSA we have tried to promote that. And it's a particularly important area because for many years the suicide prevention field was really not paying systematic attention to the experiences because we can't talk to those who have already died by suicide. Of course we can talk to their families and we should talk to their families. But having people share with us not only led them to be suicidal, but what helped them survive, what helped them get through that is vitally important. And there's some evidence that those messages of hope and recovery can have a positive impact as far as suicide in the general community.
One thing I can add is on a frequent basis we work with individuals who have experienced a loss of suicide, so family members. So at least twice a year we are involved in the Tragedy Assistant Program seminar, and we actually we go to those individuals who have survived a suicide attempt or those individuals who have had service members who've died by suicide, and we get their direct feedback, especially around postvention and how we're handling suicide deaths and whether or not we're taking the right actions and what can we do better. We had a research study about a year ago where we did many interviews and research on do we handle military service member suicides in the proper way. And many of those individuals who gave us feedback were involved in the Tragedy Assistant Program seminars that we participated in. So we get that direct feedback and it's been very invaluable.
Any other questions? Yes, right there.
I was just wondering if there's any numbers out there that sort of go over vets that have gone back to school versus vets that have come out of the military and have not gone to a university. If there's any sort of numbers like that.
I don't have any data on that, but it's definitely a good question. One thing I do know is in the literature it speaks to the importance of education as a protective factor. So those that have increased education end their life by suicide less than those that don't. So it is a protective factor. Otherwise, I know if you heard me talk about the data on 18 to 34-year-olds, we do have a strategy right now where we're trying to meet with veterans or get after this issue where they live and thrive, and we believe that is in the university sector, particularly in community colleges. So we're trying to build our partnerships in that space so that we could have that be like a force multiplier for our programming. but I don't have exact data. Hopefully that helps.
If I could, I'll just mention
Yeah.
two things quickly. One is in our campus suicide prevention program, we do pay particular attention to the needs of veterans who are returning to campus there. So that's one thing. The other is that I think the role of education as a protective factor in suicide prevention, probably the most systematic work has been done by the Princeton economists Case and Deaton, who have talked about the deaths of despair, and their work shows that there's that the rates are really different when you look at college educated and above versus high school educated and below. We need to understand better why that is, but that's an important piece of work to be aware of.
Another question? Yes.
I run a father's rights crisis line where I answer calls, and a wounded combat veteran told me that being injured in combat wasn't as bad as the pain he felt in parent alienation when a spouse uses the children against him in court. I was wondering if you had any experiences, and I know of a father who's a Navy veteran, 20-year Navy veteran. He twice attempted suicide, highly decorated, top secret, etc. Do you have data on the interplay between divorce or men going through divorce or going through a toxic divorce and suicide? That's my question.
Yeah, there's been quite a number of researchers that have studied this issue, both on the active duty line of work and just in society. And relationships are an important risk factor, absolutely. And it's not always marital. It could be in any manner of interpersonal relationships. That is something that you see in a lot of our suicide deaths. Reference my colleagues talk about the importance of autopsies and fatality reviews. When we study our deaths after the fact, we see that there were deterioration of relationships with significant others, and it was chronic, like it existed over time. So it is absolutely a risk factor. I don't know specifically about the child piece. I've spent some time myself studying parental absence and how that impacts children over time and their own emotional well-being and development. So for example, when parents are in and out of that parenting role, usually because of job requirements, not because of a nasty divorce, but disrupted parent-child relationships over time are problematic, and there is research on that, yeah.
Thank you.
I'll just add that in some of our death reviews of active duty suicides, we know that there's been a failed relationship or a very stressful relationship discord about 7 days before an individual dies by suicide, and that seems to be a recurrent pattern that we see in some of those deaths.
I'm reminded too of just a study from some analysis from the Marine Corps where, if you remember this work, Adam, the parents that were separated from their children, and that being a risk factor when they were still the primary parent, but they chose to stay in one state, and the family stayed in one state and the parent moved on, and that being a higher risk.
Yes. Yeah.
Do you remember that?
There was some work
Can't
that
remember
was
the particulars.
done out of Penn State University that showed some of that marital and parent discord. It showed if there was, if one of the service member didn't have access to a child or frequent visitation, they showed that there was an increase in suicide risk.
Thank you.
I couldn't remember the particulars, but I knew you would.
One more quick question?
Yeah, so I remember seeing a statistic that 50% of the suicide rates did not have a diagnosable mental illness. Can you explain why is that, and like how do you go about reaching out to those people?
Well, in terms of the number, you're probably referring to the CDC report. It's based on data from the National Violent Death Reporting System. So it was 50% having a known mental health problem there. So, but two things to be aware of. One is that that did not include substance abuse. So if you add substance abuse, that number goes higher. It also did not include undiagnosed mental health concerns. So that's just one thing to be aware of. But certainly a huge issue is people who have not sought help, as Adam talked about. How to encourage help seeking when somebody's thinking about suicide is usually important. So I don't know if either of my colleagues wanted to talk about outreach in that situation.
Well, I would just add that, yeah, in the DoD, very consistently, we've seen in the numbers that only about 50% have a mental illness. And I would say that that's actually consistent around the world. Many other countries, from Malaysia to India to China to many other countries, they don't show those higher rates of mental illness and suicide. So I would say that I would explain that by saying that there's a lot more going on than mental health. Mental health symptoms can increase risk for suicide, but the environment, access to lethal means, is a very strong predictor of suicide. So having immediate access to a lethal means of suicide, because as we know, suicide can be impulsive. So that's another thing that is going on in addition to mental health. So that mental health is one part, but certainly not the whole picture.
Great, well, let's give another round of applause to all of our panelists. They're going to be around if anyone has any other questions. Thank you all for joining us. Please go back to your offices and let your bosses know about the Congressional Men's Health Caucus. Men's Health Network, our team will be going out and doing new member meetings in the next couple months. So letting all the new members and their staffers know about what the caucus is. If anyone is interested, please contact Markwayne Mullin's office, Taylor Hiddle in that office, and then Congressman Payne Jr.'s office, we have Stephen Schultz there. So please let them know if your boss is interested. Thank you. Have a wonderful day.